Well, hi, this is Dr. Larry Robbins again, and this is part two of the Neuro Exam, Clinical Pearls. We do have an expanded version of this in my newer book, Stuff You Should Know by Lawrence Robbins. And we have part one on, and I'm going to do part three of the Neuro Exam. The only reason that the Neuro Exam is so long is the cranial nerves are so much there. So this part two is basically just the cranial nerves, and I'm going to hit the highlights. So we don't love it when people say cranial nerves 2 through 12 intact. They usually haven't checked all of those. And what about number one? Smell is pretty important, and taste. Of course, if somebody's not complaining of smell and taste issues, we don't usually test number one. And that's true throughout the neuro exam. You usually do a target exam based on the history. And while you're talking to people, while you watch them walk, we're doing a neuro exam there. If they're not clearing their throat constantly or coughing, they probably don't have a problem with cranial nerves 9, 10, and 12. So we really just target things. Some neurologists do carry coffee and sugar and salt. Alcohol is not great to test, but anosmia can result really from a variety of problems. Trauma to the head, particularly the front of the head, and concussion. Viruses, and it's very common, of course, with coronavirus, but aging and Parkinson's, loss of sense of smell is common as an early or a precursor to Parkinson's and other neurodegenerative as well. Unilateral is usually just intranasal pathology. Now, cranial nerve 2 basically has three parts: the pupils, visual fields, and acuity. The extraocular muscles are not two. There are 3, 4, and 6. And it's not truly a nerve, it's really more of an optic tract. There's some misnamed designations in the central nervous system, like basal ganglia. Ganglia are usually outside of the CNS. And with the pupils, it's very common to find one a little bit smaller than another, and it's usually physiologic or essential anisocoria. So the patient usually will say that somebody's pointed this out, or a previous eye doctor, or other people. And indeed, if the pupils constrict in dim and in bright lights, constrict well, it's usually physiologic or essential anisocoria, and you don't have to do anything. Also, it's very unlikely for somebody walking in your office and doing a routine exam to have pathology where they're going to have a blown pupil, etc., unless they have diabetes, etc. And even with diabetes, it's usually the inside of the nerve, and it's pupil sparing, usually. So in neurology, we usually do test visual acuity with glasses or contacts. We're not as concerned about the uncorrected vision. Unfortunately, we are losing our ability to look behind the eyes. That small ophthalmoscope is really from the 1800s, not much different. The panoptic is much easier, but it's still expensive, $500, $600 even on eBay. But it does expand the view. Artificial intelligence is going to be used in the ER quite a bit, where you take a picture of the back of the eye, run it through the AI program, just like with an EKG, and you get a good indication of papilledema or not. Actually better than even having ophthalmologists look behind the eyes. But I do think that the fundoscopic exam should be practiced. It connects you to the patient, the therapeutic touch, you're near the patient. And the more if you just can see right to right, say you're right-handed, your right eye is dominant, say, you can just look in their right eye, and you want to see if there's early signs of papilledema, etc., particularly in the ER or in emergent situations. The visual fields, it depends. If we have an intact, cognitively intact patient, whose sensorium is fine, you may be able to find a quadrantenopsia or a little visual field cut. If somebody is stuporous or delirious, you may only be able to get confrontation and a very gross visual field exam. We don't like saying perla because pupils equal and round and reactive to light and accommodation, but we're not really checking lens accommodation, which is vision up close. We're checking near, we're checking can the pupils constrict, we're checking can they converge, can your eyes converge, but we're not really checking accommodation. Now 3, 4, and 6 are your extraocular eye muscles. 3 has several parts to it. It's a large complex there in the midbrain. And there can be a compressive lesion more with an enlarged pupil. With diabetes, usually it's not so much of a blown pupil because it's the inside. And 3 does most of our extraocular muscles. Cranial 4, the trochlear, isolated cranial 4 lesions are not very common, but it's a superior oblique which moves our eye down and in. We'll have a characteristic head tilt. And 6, of course, is a long nerve, very important nerve, and many conditions, increased pressure, tumors, etc., can affect 6 along the way. And that, of course, goes to the lateral rectus, which moves your eye out. The smaller eye, if somebody has a smaller eye, you have to figure out if it's a muscle of Mueller versus just a levator coming down with ptosis. So testing for diplopia can be tricky. Usually with horizontal, it's the far out image, the most lateral image, that's the false one. So it's always a question, is it a third on one side or a sixth on the other side? You can use the red glass test, and usually the false image then is the red one if it's the most far out one. And you can identify which one, but it can be tricky to do this. We're talking about binocular diplopia. If it's just one eye, it's usually intraocular pathology. Now, cranial nerve 5, the jaw muscles are pretty strong, and they can be weakened, and you'll still be able to bite down, and it's tough to tell. Your corneal reflex, of course, involves cranial nerve 5 on one side and 7 on both sides. If the corneal is absent, you have to determine which it is. If 7 is okay on the other side, it's usually cranial nerve, it's usually 5. It's usually an issue with cranial nerve 5. So you have to determine, but usually you'll get some indication that 7 is a problem by looking at your facial nerve physical exam. The dermatomes do overlap, so splitting the midline, if somebody says they can't feel on the right side of their body and their face, and you move the pin or cotton swab or Kleenex over towards the middle, and suddenly there's a sharp demarcation, that could be malingering or factitious. We're usually testing pin and light touch, or always comparing one side to another with a neuro exam. The issue with cranial nerve 7 is usually determining central versus a peripheral 7th. Central is supranuclear, where we have bilateral innervation, so we won't get a complete weakness. You can close the eye. You won't bury the eyelids nearly as much, but you won't see the eye rolling up. You won't see the white of the eye when they close it. You can call it Bell's palsy. I think it was Thomas Bell in the 1800s, or you could call it Bell palsy. Bell palsy is sort of cool because everybody calls it Bell's palsy, and it's not wrong. It's not right either. You can also call it Bell's palsy. But there is complete weakness. It's a peripheral 7th, infranuclear, and they certainly cannot bury their eyelids, and they can't close their eye. And certainly with a Bell's palsy, you're going to need to protect their eye for a number of weeks until they can close it while they sleep. But the neuro exam is very interactive. We're always telling them, do this, do that. We're touching them, so it's the therapeutic touch. With the seventh nerve, we're always asking them, close your eyes really tight, 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 squeeze, 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 squeeze. And people have to be able to cooperate. We also can check the nasolabial fold. You can check taste from the anterior 2/3 of the tongue. The posterior third is the ninth nerve. And a peripheral seventh will give you hyperacusis, hearing louder on that side. 8, we usually check hearing grossly by whispering in the ear, and with distraction it helps. So you're rubbing your fingers in the other ear and distracting their brain, just like in a crowded restaurant or locker room. And you can give them 10 objects and see out of the 10 how many they can repeat back right away. So you don't give them the 10 and say, let me do that. That's more of a memory test. So you would say elephant, ball, and see. They should get 9 or 10 out of 10. The Weber or Weber is the 128 hammer, vibration hammer. It's only really accurate in a pretty quiet room, and how you phrase it to the patient matters. Do you hear it on this side or that side or more in the middle? So it may not be the greatest test, except it's a good test for malingering if they say that everything is not working on the right side and they only hear it on the right or feel the vibration on the right. When you go in their forehead from the left forehead to the right forehead, it's all one skull bone, so they should hear it exactly the same. But if they're malingering, they'll only hear it on the right. The rene or rina is often asked where you put it on the bone and you say, let me know when you don't hear it anymore, and then you quickly move it to the ear. But that takes a while, and it's not that accurate. You have to very quickly move it to the ear and ask them. A faster and more accurate way is just put it on the bone and then quickly move to the ear while it's still going and ask which is louder. And I think that's more accurate. So during your history, 9 and 10, if they are coughing, if they have suspected motor neuron disease and they're clearing their throat, it's a bad sign for bulbar weakness. But if in your normal person you don't usually check 9 and 10, we can have them drink a water, drink from a glass. You know, everything neurologically has to be intact when you drink and swallow. Swallowing is a big problem. So all kinds of problems, cervical, spine surgery in the 60s, at least 12, 13% of people get swallowing problems after, and a year later, 4 or 5% are still having some swallowing problems. It takes a lot. We're really more concerned with palatal raphe weakness than with deviation of the uvula. It's just not all that accurate, so we look to see if the raphe goes up. If somebody has a lot of anxiety and they can't swallow, the old term globus hystericus is still pretty descriptive. Now, cranial nerve 11, shrugging the shoulders, turning your head. These are the usual maneuvers, but these are strong muscles. So if somebody is fairly strong to begin with and they lose 40% of that, you may not be able to pick it up. And be careful in older patients. You never want to fracture anything, and this has been done, checking this, pushing down on their shoulder in an 82-year-old with osteoporosis. It's just not great, so be very careful. And cranial nerve 12, with hypoglossal canal lesions, you may pick up motor neuron disease. You may see unilateral atrophy. You may see fasciculations after a while. It doesn't happen right away, but you may pick up fasciculations later on in bulbar palsy and motor neuron disease that affects the tongue. It really looks like worms crawling. But usually their speech is pretty garbled with a 12th nerve lesion, and you have a good indication during your history. So I think what we'll do is end part 2 there, and the rest of the neuro exam we'll have in part 3.